to this Surginar again. This is the second in our series in the COVID era, and we are today at Girdhar Eye Institute, Cochin, which is NABH accredited hospital, which was established on 8 September 1997, and it is a we have with us today Dr. S. J. Sai Kumar, who will be operating, who's a medical superintendent and head of cataract and glaucoma services, and Dr. Girdhar A., medical director and chief mentor, who's going to be doing retinal detachment surgery. We also have Dr. Mahesh Ji with us, senior consultant and head of the Department of Vitreoretina Services, who's also the chairperson for the Kerala State, secretary of the Kerala State Ophthalmic Society, and Dr. Vinay Sukumar Pillai, senior consultant and head cornea and refractive surgery, Dr. Marian Colley, senior consultant and head oculoplasty, orbit, oculo-oncology, and oculoprosthesis. And there will be a demonstration of 3 cataracts, 2 intumescent cataracts, and 1 nuclear cataract. And apart from this, they are also going to be demonstrating the retinal detachment surgery. I have with me our president, All India Ophthalmological Society, Dr. Mahipal Sachdev, and treasurer, All India Ophthalmological Society, Dr. Rajesh Sinha. So without much ado, I think we'll begin the surgical session, and I would request Dr. Mahipal sir to say a few words before we commence the surgery.
Good afternoon, everybody, and a very happy Holi. Welcome to this Surginar, which obviously is going to showcase various surgical techniques. Primarily, this particular session is to look at different difficult situations in cataract, and that is the intumescent cataract and the hard brown cataract, and also at a macular hole surgery. The Girdhar Eye Institute, as we all know, is one of the leading eye institutions in South India, which is doing yeoman service as regards doing tough and difficult cases, and it's at the cutting edge of technology that is there. So we are thankful to Girdhar Eye Institute and the surgeons for having arranged this Surginar, which will actually give the delegates from across India to see, and abroad, I would say, to see the various techniques and to ask questions. So we can go ahead with the surgical session being started now.
Good afternoon, everyone. I'm Dr. Sandhya from Girdhar Institute. Dr. Sai Kumar is doing the surgery. Our first case is a 53-year-old lady with an intumescent mature cataract in the left eye. She is pseudophakic in the right eye with a multifocal IOL.
Can we have the microscope view, please?
Microscope.
Yeah.
Is the magnification correct, madam?
Yeah, everything is good. You can start, I would say.
Yeah. The mature intumescent cataract. The other eye of the lady is pseudophakic in the other eye. She's got a multifocal lens in the other eye. She should have actually done this earlier, but for the pandemic, I think she got delayed a bit. So we are making 2 paracentesis here. And obviously we're using trypan blue to stain the capsule. So these are the sort of capsules where you can get a rexis tear quite easily. I usually do the trypan blue staining under air. There are, of course, various techniques to do, but I find it comfortable to do under air. And I usually don't wash it again. I just directly put some HPMC. Viscose. And it's my preferred technique to put some viscose on top of the capsule there, air. I stabilized the globe. This patient was a bit apprehensive, so actually we have given a peribulbar block in this patient. So in case we need to convert or something, then it becomes easier. some fluid cortex coming out. Blue paracentesis. Microrhexis forceps. I'm using a microrhexis forceps here to make an initial rhexis. Cornea.
So in case, Dr. Sai, if you want to decrease your zoom, you can. For us, it is quite magnified. So
Is
just,
this okay, madam?
yeah, perfectly all right. Beautifully, I think it is getting spiral.
So we have made a small rhexis now
So
by
it's
manual.
not centered. It's not centered.
Yes, now it is okay, perfect.
Vacuum method. IA.
Okay, so initially you would make a small rhexis and then take
Yeah.
out the fluid.
And then, slightly decompress the bag here. And so that I can make a larger rhexis and then proceed. But some of these cortexes are actually slightly resistant. You can actually milk out some of the cortex like this before aspirating. Gel. Here again, I use a bit of viscose. I feel it compresses the capsule well, and it holds on there during the extension. And the microrhexis scissors is now being used to make a small nick in the capsule. And while making the nick itself, you will know the intra-bag pressure, because when you make the nick, if you see a V-like opening of the nick, that means the capsule pressure is still high. But if it is something like a straight line, then you can obviously know that the pressure is under control.
So I think this is a very nice technique that first you will do a small rhexis and then you consciously do a small rhexis and then followed by aspirate
And
to the fluid.
sometimes
Yeah.
sometimes we have noticed that even this rhexis may not be 2.4. Sometimes we notice that even this rhexis may appear a bit small once you put in the intraocular lens. And then we do a third rhexis to just make sure that the size of the rhexis is quite okay. Now, since we have already aspirated some of the cortex and this nucleus itself is not very hard, there's no need for a hydrodissection here. The nucleus rotates very well. Grade 2.
So I also noticed that you made your main incision after you've done your rhexis.
Exactly. So in case I'm having some issues with the rhexis, if I by some chance need to convert into an SICS, then I'm not committed on my main incision.
I think, Dr. Amrita, the other issue advantage is that you want the chamber to be as watertight as possible. That's the disadvantage when we do, say, a femto laser, which is a closed chamber. So you don't want an open chamber. So your main incision, so rhexis, if done from the side ports or the smallest, this thing always gives you better result. And it is always very, very safe to extend the rhexis after putting in the IOL. Like I think he might have to extend it a little bit because there'll be a large cover. Sai, can you just reduce the mag?
Magnification can be reduced.
Is that okay?
Yeah, that's fine. Good.
So I'm using an intuitive machine here. It's not a very hard cataract. Just
So you would generally like to make a trench before you finally, chop
yeah,
it.
yeah. These sort of cataracts, sometimes it's difficult to judge the depth. So my preferred technique is always a stop and chop. Of course, you can also go ahead with a direct chop also.
In these cases, it is also very important that you put the retro illumination on before the case, because sometimes what happens when you forget and you
Yeah.
do the case and your retro is on, then it always helps.
Sometimes after cortex aspiration, the nucleus will be very mobile. So in such cases, we go for a direct chop. So because of the cortex is debulked, the nucleus is very mobile, then we go for a direct chop.
So actually, the intuitive machine is a significant upgrade over the earlier compact that they had.
Correct, correct.
I will put it almost at par with the signature that was there. The Signature Pro, I would say, is a little still better as regards search control, but you can have the intuitive light with and without the effects. I think now they
Yeah.
have, yeah.
So
And
that
as
was
was rightly pointed out, at least in my personal hands, I prefer always to do a direct stop. Uh, there are very rare instances where I want to do a stop and shop.
Pranayama.
At this point, one can actually go on to the epinuclear mode.
Yeah.
You tend to have a
Chamber is got excellent chamber stability also, sir, this machine.
yeah, I know.
so Sai, that was just a textbook like picture
Yeah.
of eating away the entire nucleus, huh?
So one important thing to note is that whenever you're using a signature or even an intuitive, you can actually go ahead with a 20 gauge, 21 gauge, or even a 19. I prefer to use a much wider board, and the lumen inside is not constricted as in some other machines.
Yeah, yeah, yeah.
So if you are actually dealing with a rock hard cataract, you have to actually stop in between. You have to flush the tip and also which does not have happen in these machines.
So he whisk.
So I don't know whether you agree with me, Sai, or not, because
Yes, sir, definitely. Room lights off.
It's become a little dark side, so
Yeah. I just switched on the retro.
okay.
So which lens are you planning to implant?
I'm planning to implant a synergy, sir.
Okay, great.
Cortex saga.
So 23 diopter synergy, sir.
Okay, great. What has been your experience with this synergy so far?
Synergy, I have not implanted too many lenses, sir. I've implanted about 4, 5. So far, they've been doing good.
Okay.
And in that category, I think it is definitely better for near vision compared to the Symphony. Symphony is an excellent lens, but near vision is slightly.
Symphony is not really a comparison. I would say it's better than the other trifocals, even the
Yeah.
because
Correct.
that is giving you a good reading ability at 40. So this gives
Correct.
you a continuous range of vision starting from 33 centimeters.
Lens kuduma.
Would you wish to tell the audience something about the synergy as to how it is different from other?
I think you will be a better person, sir. just beginning to use the synergy. Just implanted a few lenses. Of course, I can say some theory, but I think you will have more experience with this synergy, sir.
Okay, you can say the theory. I will say the practical. So anyway, I think this is, you can see the tint. Can you just show the tint? It's
the slight yellow tint.
Yellow lens, but you can see that there is a mild
mild
yellow
tint
tint.
is there.
Yeah. So what it does is that it cuts out the, it is not a blue light filtering lens, but it cuts out the harmful extreme, the spectrum of the blue UV light that is there.
Okay. Sonia wash.
So therefore, what they say is that you can have effects on the circadian rhythm, etc. So that is not there. The second thing is that this is based on the Technis One platform.
Yeah.
Yeah, so it is the same, and it's the same injector which you are using.
The same injector as Technis One. Actually, all the lenses across the board have the same platform, and I think that Technis One is a very time-tested platform. And
you can use in the unfolder both the screw type or the push type.
I generally use the screw type, sir. I'm so comfortable with the screw type. I hardly use the pusher.
Yeah, because the screw gives you better control.
Control, yeah.
You can stop at any time. Sometimes the push type comes with a jerk.
Correct. It comes with a jerk. It can go and hit the capsule or the rexis margin.
So this is basically the square edge that you have. The other thing about this particular lens is that they have the proprietary technology which they have. The asphericity is obviously part of the Technis thing, and that's part here also. But the other important thing is that they have got the achromatic or the chrome-align technology. So, Sai, would you want to say something on the chrome-align, or should I say?
Yeah, I think you can say, sir.
Okay, so basically, apart from the spherical abrasions that you get on the IOL, within the eye, sorry, you also get chromatic abrasions within the eye. So that is very, very disturbing, especially in dim light as regards the bad contrast when you have. So if you cut out the chromatic abrasions by the design of the IOL, that will give you excellent vision even in dim light conditions, and that is very, very important, which is there. The third important thing which is there is that it is what is known as a CRV, or a continuous range of vision lens. I think the central 1.1 or 1.2, you start with the first ring, and there are 15 rings which are there. And they are basically a combination of what is known as a trifocal lens with a EDOF lens. So that means that within the three ranges that you have of the 33 centimeters and the intermediate and the distance, you have a lens which is an extended depth of focus. So there is actually not three distinct focuses, but there are three focuses. In addition, there is a continuous range of vision. So they prefer to call it as a CRV lens, or a continuous range of vision lens, rather than just a trifocal lens. Yeah, Dr. Said, what you're doing is an excellent maneuver of removing visco. Just tell us something about from the back.
No, we go under the IOL, and actually with a bimanual, normally I'm, most of the cases I use a coaxial for my irrigation aspiration. But when I'm using bimanual, in such cases, I reduce the vacuum a bit because sometimes the flow of fluid in a bimanual is not as good as that through the sleeve in a coaxial. So I go a bit slow, but you have to make sure, obviously, that you're removing all the viscoelastic from inside the eye.
Yeah, and it's a very well centered IOL just now. One of the things that you can do is to actually have a marker to see as to the size of the rexis.
Actually,
manual marker. Yeah, go ahead.
Actually, I also have a Virion technology with us.
Yeah.
So we use that in most of the cases.
So would you be extending the rexis in this, or you think it is okay?
It looks good enough to me, madam.
Yeah,
I'm not planning to extend, because one area it is slightly smaller superiorly, but the rest is quite okay. Now, if I try to extend it and it becomes too large, then positioning becomes an issue. So I'm planning to leave it like that.
So basically, sometimes if you have a very small rexis, you get phimosis, and you can have a problem of a decentration. And the other thing is that dysphotopsia can become disproportionately large because of the interplay between the rexis and the lens.
Yeah.
So
but in this lens, except for a small area superiorly, the rest of the rexis is almost aligned to the last ring of the lens.
Yeah.
Yeah.
I
And
think-
one of the tricks to do a rexis at this particular time is maybe not to use a scissor. You could actually use the iris repositor kind of a spatula, which you put below the rexis, lift it up because the
And-
lens is there, and then do a small needle.
Small nick with the needle. Yeah, yeah. That was the
And
initial
then-
technique. Yeah, yeah.
Yeah.
I'm through, sir. Madam.
I
Great.
know it was such a effortless thing, Sai, that we, we before we realized the case was already over. Very well
And
done.
we have also put in some intracameral moxifloxacin, but now as a standard, we are doing for all cases.
For all cases.
Thank
Okay.
you, madam.
Do you think it has reduced your incidence of
Definitely. I mean, we have not done a study as of now, sir, but definitely touch wood. I don't have any wood here to touch now. But we have not seen a single case of endophthalmitis after having started the intracameral moxifloxacin
You can touch your head.
so far.
Okay, so that was
Can we
very,
shift? Yeah,
yeah,
can we shift to the retina side, sir?
yes,
So
surely.
any comments you want to say? It's important to seal the incision. At times, some people use a dye to see that it is well sealed, because the endophthalmitis happens only in the earlier period when the wound is not tight enough and you can
Correct.
We'll
Yeah.
talk about that.
Even if you look at the large
will ask him.
ESCRS study of endophthalmitis, which started propagating cefuroxime,
yes.
the incidence was actually much higher than even in our country. So, but then the initially, the wound construction, there were a lot of issues. But with the smaller wounds that we have now, I think that also has gone a long way in reducing the incidence of endophthalmitis. It's not just the moxifloxacin alone.
Do you have an access to flax?
Yes, sir. We have flax. We regularly do flax.
So
Yeah.
you're not showing flax.
Not today, sir.
Ready, we
Right?
will stop here and go.
Yeah.
Okay.
Thank you,
Then
sir.
we'll
So
come
we'll
back
shift to
again.
the retina side while
Yeah.
I get my next intumescent cataract ready.
Okay,
So
thank
don't
you.
you prefer to use a flax for intumescent cataracts?
I do, sir. I do, sir. Today we are not demonstrating that, but I prefer to do a flax in such cases where the
Mother
rexus
had
is
a-
very effortless.
Mother had a
You don't have to worry about this nick and extension and things like that.
Mother had
But I thought that
No.
how many people watching today, I mean, I don't know how many will have access to flax.
No,
Flax.
that's what I'm trying to just ask you, because is your penetration of femtolaser increasing as regards the percentage of the total cases?
Right from the beginning, it's been remaining about 10%, sir.
That's
Between 8 to 10%.
Okay.
During the pandemic times, it was actually a bit less
Hmm.
because people were having some affordability issues, but it has picked up again. So I would say it is roughly about 10%. So if I do about 300 cataracts a month, about 25 to 30 will be flax. It hasn't increased beyond that.
We are seeing a significant surge in Delhi, I would say, as regards the femtolaser procedures, and the numbers have actually gone up. I was talking to a representative of J&J. They have sold the maximum number of LOIs ever in their lifetime
Okay.
in January, in February, and March.
Okay.
Can we shift to the retina?
Yeah, can we shift to the retina side? Yeah.
So Dr. Girdhar is going to demonstrate retinal detachment surgery, and Dr. Mahesh is there to help us to moderate.
Yeah, because both of us are not knowing
Yeah,
anything about
yes,
retina.
yeah.
We have forgotten the spelling of
Oh.
retina.
So that is why I was I asked Dr. Sai also. I hope somebody is there from retina side.
I think Rajesh, if he's there, he can.
So this is a pediatric RD.
Okay.
Actually, we
So
have
even more
കഴിഞ്ഞു എല്ലാം നന്നായിരിക്കണോ കുഴപ്പമൊന്നുമില്ല കേട്ടോ
macula
ബാൻഡേജ്
bone.
വെച്ചിട്ട് ഇപ്പൊ എഴുന്നേപ്പിക്കാമേ
What I'm showing
Check.
is
Can
a
we, can we
shrunk
mute Dr. Sai's this thing, mic, and start?
Yeah.
Yeah. Yes, Dr. Mahesh.
Yeah. Actually, pediatric, but that was somehow cancer. This is a bigger case, but so that's why we are showing it parts. Dr. Girdhar is doing the case. It is under general 17-year-old boy with nearly total RD. We are doing a scleral buckling, which is a classical retinal detachment surgery, rather a dying art. I can ask Dr. Girdhar, why is scleral buckling?
Well, pediatric RD is actually I mean, as much as possible, we should try to fix the retina with a buckle because basically the vitreous is formed and peripheral vitreous removal is very difficult. So basically, this is a patient with a bullous RD, but the retinal lesions are very peripheral. So unless in a pediatric RD, unless there is a GRT or a PVR or multiple posterior breaks, we usually don't do a vitrectomy. Although many new retinal surgeons are not trained very well in buckle, so they may go in for a vitrectomy, but I feel that vitrectomy in such cases can lead to a lot of complications, and chance of recurrences are high, chance of cataract formation, oil insertion, even the visual acuity recovery may not be very good. So there is a 90% chance that this eye may settle down with a buckle. So that's why we are doing a buckle. So conventional surgeons, old timers like us, we are still doing a lot of, a few buckles every year in these sort of situations. So what I'm showing you is putting the suture for the scleral explant. So what we do is we put a scleral explant covering the area of the retinal breaks. So this is a scleral explant. So we use two types of sutures. One is the Ethibond and the other is the Dacron. So we keep it's a spatulated needle. So we keep it flush with the sclera and gently snug it into the half thickness of sclera. And
transmission from here, this microscope is excellent. I mean, you can make out every single vessel and every very nice transmission.
Actually, this is something like we all do retinal drawing before the surgery, some rough drawing. And the patient is having upper part, 2-3 lattices and a break.
Can we
and that area is being supported by the buckle.
Can we put spotlight on what Dr. Mahesh is showing? Because right now we are seeing a microscope view. Can you put it externally?
Yeah. Okay.
Yes, Dr. Mahesh.
So, I mean, this is the drawing. Upper part is having retinal break with lattice degeneration. Yeah. He is putting explant sutures using either Dacron or Ethibond, both are non-absorbable. We use explant either.
This particular step is very important. I can see here you keep the needle flush with the sclera.
Microscope.
Keep the needle flush with the sclera and gently with seesaw movement, you just move the needle. It should be done very carefully because the needle should be held parallel to the sclera, not obliquely to the sclera. And since it's a spatulated needle, it just beautifully goes inside. So this is the superior oblique insertion, which we are trying to avoid while putting the explant suture. So you can continue, Mahesh. You can show your diagram now.
Yeah.
Can we have on the
the initial steps we have not shown. Actually, it is a nice peritomy, separation of tenons capsule and muscle tagging. The tenons has to be very carefully separated because the young boy, they will have thick tenons that is separated. And then the next step is cryo. In this case, it is little bullous, retina is little bullous, all quadrant. After keeping the sutures, we will drain the fluid and then give cryo to the lesions. So it's a reverse order. So we are covering with 2+2, 4 sutures and 279 buccal explant is used. Myra explant is used. Yes, sir.
Yeah, I think, that's the next step after this is the drainage of subretinal fluid, external drainage. So probably that we will demonstrate after the second cataract is shown. This is the last suture I'm putting here, the last explant suture in the inferonasal quadrant. So the surgery actually will take about 60 minutes, 60, 75 minutes totally.
Yeah.
Yeah.
I think again that was a very nice demonstration of how one should actually take the suture, just like you showed before.
So that's the measurement. Be careful. Yeah. Two forces.
That is a vortex vein.
Hmm.
So we try to avoid the vortex vein actually in these sort of situations. You can either start on one side and then take one bite here on the other side.
So this I understand is to avoid the vortex vein.
Yeah, this is to avoid the vortex vein. So when the vortex vein is going, either you go to an area where you don't have the vortex vein at all, that is somewhere here, but then here there's not enough space. So I make it into two parts. One is this side, and the where the vortex vein is just bridged. Yeah. Most of these patients, they have a little bit of atypical anatomy actually. The position of the vortex veins, the position of the insertion of the obliques, etc. We normally see some anomaly at times, especially in high myopes. But this patient is not a case of high myopia. Yeah, this is the last suture.
Shall we continue drainage or after the cataract?
I think we'll put the groove measurement. I don't know. I'll just see whether I think we can finish off the drainage or
Yeah.
put a groove now.
There is a question on the YouTube, and it says that in buccal surgery, is it advisable? I think we've not reached there, but still, in buccal surgery, is it advisable to put air or saline post drainage for hypotony? And if we put air, can moving air cause break in case of incomplete PVD?
I usually don't inject anything into the vitreous cavity. I mean, in a buccal case, even if there is hypotony, I just leave it like that because it just settles down. So there is no need to inject anything. Now, in some cases of bullous RD, when there's a lot of fluid, if you want to do a near complete drainage, after initial drainage, you can inject a little bit of saline BSS into the vitreous. That may, increase the IOP and that may facilitate further drainage. But in my experience, so many years, I rarely inject anything into the vitreous cavity except probably a small bubble of gas sometimes, as if I need some tamponade, which doesn't do any harm. The chances of PVD induction and complication, I don't think it's that common. No?
Yeah. This is the fourth quadrant where we are not putting a suture and just putting a tunnel.
That's a good question.
Mm.
Whomsoever has asked, that's a good question. Actually, in this particular case, yesterday I was just wondering whether I should think of injecting something in the middle of the drainage from the knife through, because it's a bullous RD, lot of fluid is there. So
Out of all your retinal surgeries, what percentage would be your, buckling surgeries, and what percentage would be your non-buckling surgeries?
Actually, we do buckle only in selected cases. There was a time when we used to do buckle in most of the cases and do vitrectomy only rarely. But now, only pediatric cases, and some those cases only we are planning doing.
buckles
But
are very less now.
very less,
Very
probably
less.
5%.
Yeah, 5%.
Something like that.
5%, exactly. It's about 5% only. In fact, nowadays when we see a detachment, we first see whether we can do a bit vitrectomy. So buckling is earlier it was the other way around. So measurement.
Shall we drain or go from there? They are ready.
My next step, then let them show the cataract.
Yeah.
Show the insertion
So,
of the tire and all.
Till the drainage. Then that time we will.
Okay, thank you, Dr. Girdhar. We'll come back to you again. But the transmission is excellent. Every single fiber of the muscle can be seen, on our laptops from your institute. So it's too good. So
thank you, Namrata. And I appreciate your, you're very, you and Maipal, you have really taken AIOS to a very different level during the pandemic.
Thank you so much, sir.
We don't have to repeat this pandemic again. It comes to an end fast. Wasn't the most pleasurable job. But anyway, thank you. We can we shift, sir?
Yeah. Yes, sir.
We'll shift to the second cataract, sir.
This is a filler.
Yeah. Okay.
So this is the main movie. Others are fillers.
Yeah, cataract are fillers because you will continue till the 3 are done. Okay. Yeah. Again, Sai, you are operating again?
Yeah, yes, sir. Second case I'm doing.
You seem to have changed the machine, right?
I've changed the machine.
So can we have the microscope, please?
Next step.
I think Dr. Sandhya will just introduce the case once again.
Second case is a 50-year-old lady with a mature cataract in the left eye. We're planning to put an eye hands in the left eye. The first case, the nucleus sclerosis was not, the nucleus was not very hard, but in this case, we have got a hard nucleus with a mature cataract.
Thank you.
Microscope view, please.
Yes, Sai.
Is it visible, madam?
Yes, perfect.
Why do you say it's a hard cataract? It still looks.
It's not very hard. It is slightly harder compared to the first case.
Okay.
It's not very hard.
Yeah. What do you put? Is this Phenocaine or something?
No, I put Phenocaine plus for all cases.
Okay, so this is Phenocaine plus. Can you tell the audience what is Phenocaine plus?
It is a combination of local anesthetic with tropicamide and phenylephrine.
Yes.
And which is very useful for our topical cases. With one medicine, you can get both a bit of surface anesthesia as well as mydriasis. So I'm using quite regularly now. This elderly lady has got a bit of tremors. Okay. So please excuse me if you find the eye moving.
As long as you don't have tremors, it's fine.
I have to move along with her, so it's better that I have a bit of tremors.
Good.
Sir, Dr.
Actually, the point is that in India, this combination is pretty good. There's another, the one that is in US, which is Omidria, that has ketorolac, and that costs about $100-200. It's very, very expensive. But I think this is a good service to the Indian ophthalmology to have got this Phenocaine plus, and that's a great Rexes you are doing.
excellent rexes, Dr. Sai. And this one you did without making it smaller, just the
Yeah,
size.
this we can, yeah, this there is not much of very high intra-back pressure, so we can get away with a straight rexis without having to do a double rexis.
So the importance of just doing it through the side port is there, and now he's making the primary incision.
Here I will make a very gentle hydrodissection. In these cases, hydrodissection should not be very vigorous for two reasons. One is the posterior capsule itself may be a bit brittle and you can have a blowout. And secondly, the rexis is also not very large like in an SICS. So you have to put small aliquots of Talayanakar. Right?
So, Dr. Sai, in which cases do you do an SICS if you still do it?
I still do SICS for very, sort of pearly black cataracts, where I think, it is in my hands, the corneas are much better with an SICS than with a phaco. And secondly, when there is very high astigmatism, somehow I find that, especially the temporal steep astigmatisms, I find that if I soft tip a normal tip.
Why not a toric?
Pardon me, sir?
Why not a toric?
Yeah. Of course, toric is an option. That's a soft tip, normal tip.
I think I have been trying to push the companies to have differential pricing for torics as regards small cylinders. Cylinders, because then it becomes more acceptable to the doctor and the patient.
Correct. Actually, we should be doing more torics. If you actually look at the number of astigmatisms that we see, we should be doing more torics, but then quite often the cost becomes a deterrent. 3.
I also noticed that you use viscoat in these intumescent cataracts rather than Helon. So
rather than sodium hyaluronate. I somehow feel that it is retained more in the eye.
Okay.
Much more than the other sodium hyaluronate, which usually comes out as a single blob.
You're absolutely right. There's one company which came to me and said that the behavior, they've launched a new, I think BS5 or something, then launched a new sodium hyaluronate which says it behaves more like chondroitin sulfate. I'm not very sure about that. But chondroitin sulfate is supposed to be much more cornea friendly than the sodium hyaluronate. Do you use Indian equivalent of?
I do, sir. I do. I use what is called Orocort Plus.
Okay.
Which I find is quite okay. No financial interest in any of the products that I'm mentioning.
One of the important things that you are showing in the chopping is that you really don't need to go to the periphery. You just hold the center, go deep enough, and you just chop from the center.
Yes, sir.
The center cracks, the periphery follows. So a lot of learners actually tend to go to the periphery to try and chop. That's a superfluous kind of a thing. See this. This is nicely shown that you are near to the center. The depth is important for the tip, and you just and you are able to do the dissection. What you have done is that you haven't started to empty the bag till the very end.
Yeah. I am very comfortable, doing all the chopping maneuvers first. And then start eating the pieces one by one. Then the quad.
Are you using the Ozil?
I am using the Ozil, sir.
Okay. Do you have any observation as regards, say, in Femto or in Ozil that the pieces, small pieces, get stuck somewhere in the iris because of the horizontal movement that is there?
Yes, sir. Ozil definitely. we are seeing small pieces and sometimes even retained, small epinuclear fragments
Yeah.
surprises in the post-operative period.
You're absolutely right. That is one observation which has not been brought out. I have been thinking of writing a paper on it, but at times you
I have also observed the same, sir.
Yeah, you stop the steroids and the patient flares up again and comes back.
Correct.
Then you do a more thorough examination and you see one small little teeny weeny piece stuck somewhere of the epinucleus or the nuclear piece, because the horizontal movement somehow pushes the pieces to the side.
Pieces away, yeah.
Yeah, that is why in the femto laser I have stopped doing small fractionations. I do it at 1,000 or 1,500 or just the 6 quadrants.
Okay.
And Dr. Sai very beautifully
Yeah.
just follows your this thing, commands like a textbook picture. It comes.
Nice followability we have.
I think the Rex is fantastic in this case. This is perfectly sized. The important thing in all this is that when we started phacoemulsification way back in the 90s, the machines have had a quantum jump.
Yeah, definitely.
Slow, steadily, but now it's basically everything gets pulled. It's all vacuum based, fluidic based, and vacuum based aspiration rather than using brute power to cut the nucleus.
So again, something which we have been discussing on other platforms also. Ever since iHands has come, has your iHands changed the way you practice your monofocal lenses?
Not really, madam. iHands, most of the patients, or at least in our institute, when they accept iHands, are patients who initially want multifocal, and then when they hear about halos and glare and all, then they want a good alternative. And in my experience, also the near vision, especially when you do just one eye Cohivisc, has not been too great. But definitely, when you implant bilaterally, intermediate vision is quite good.
So, Sai, just my 2 cents to you. One is that the first patient that we were, surgery we were discussing as regards femto laser.
Yeah.
I think you are leveraging the power of femto laser, because at least in my hands, my conversion is about close to 70% being femto.
Oh, that's very high, sir. Yeah.
And hopefully this March we'll be possibly doing 500 femtos in a month.
Oh,
so that's the power of femto that is there. So the numbers are actually going up very exponentially, and it becomes a kind of a cascading effect, because there are so many machines in Delhi. People come and ask for it, and the biggest thing is that if you have 2 people, somebody handling the machine outside and somebody inside, the time taken goes down.
That is what I do, sir. I have 2 colleagues, Dr. Lakshmi and Dr. Jilu, who handle my femtos, and then I actually have not gone into the femto room for some time now.
Okay.
And along with me, there are a few other surgeons also, Dr. Sandhya, Dr. Vinay, they all do femto.
And the second thing is to price it right. I think when we started femto, I'm not very sure when you bought the femto, but we were advised to keep a differential of 50,000, which was more than the delta was higher than the cost of the cataract surgery at that time. That was a bane. So I don't know what you are doing.
We are also doing about 45,000 to 50,000 more than the normal equivalent non-femto cases.
Yeah, so basically you need to bring that down. That's my 2 cents to you. That
and increase the numbers.
The numbers will go up exponentially,
and then the volumes will take care of offset the
sure. And the second thing that you're talking about, the iHands is never ever to be sold as a option.
As a multifocal lens. Correct.
We call it as a monofocal plus, and I actually don't tell anything to the patient that I'm putting a different lens, because the cost is almost the same as a single piece good lens that is there to the patient as regards the suggested retail price. So the patient is very, very pleasantly surprised that the patient does not have any dysphotopsias. the patient tends to get as you rightly said, the ad is lower. It's about 1.5 to 2 diopters.
Yeah, that is the.
And if you do a monovision, a mini monovision with the bilateral implants, the patient, a lot of them are able to do majority of their work otherwise. So in my practice, at least my monofocal practice has significantly been taken over by eye hands. I don't tell the patient that I'm doing anything else. So I am not telling.
But what would be your cost, sir? Suppose you compare a Technics one with an eye hands.
It's only 3,000 rupees difference in the MRP. So where the patient is paying 55,000 or the patient is paying 95,000 for a femto, he just pays 3,000 extra. That's it.
Okay.
So basically, why do you wish to say anything? Supposing I have a preloaded lens or some other lens, their suggested retail price is the same as the eye hands one. So you pleasantly surprise the patient for
intermediate vision.
Yes.
With bilateral implants.
Don't raise the expectations. You don't do anything. I don't tell the patient. And even if the other eye has a monofocal, there is no issue in putting an eye hands in the second eye.
Okay.
The patient says, "Doc, what have you done in this is the second eye? I can see better in the intermediate."
So, Sai, I think beautiful demonstration of both bimanual in the previous case.
Yeah. I just used coaxial here to clear the, because otherwise we'll have to keep on changing the vacuum. As I said before, I usually go for a low vacuum in bimanual.
So I think, do you have any complaints with the eye hands ever?
No, sir, not much. Yeah, because we, as you said, we never promote the eye hands as a multifocal lens. So we just a few patients that I have had who have raised significant concerns for multifocals. They have been quite happy with the eye hands, because they are patients who had significant glare before cataract surgery with thick posterior subcapsular cataracts. So when you tell them about possibility of glare and halos in the post-operative period, they are very worried, because their primary complaint in the first place is glare and halos. So in such patients, I tell them that there is a good monofocal lens, bilateral implant, you might get a bit of intermediate vision. They're quite happy with that.
So I think the game, total game has changed over the last 2 years, I would say 2 to 3 years, where when with the advent of the trifocal lenses, the glare dysphotopsia has gone down significantly.
Yes.
You're talking about a bifocal lens, that was true. Even the glare halos dysphotopsia went down, but then it was.
But then Symphony was not very good for near vision.
So I think the CRV lenses and the eye hands are the two lenses. The only problem is that both of them are not available in their toric version just now. So once we have the toric version of both of them, I think they will take away.
They will take over the
practice.
So both if eye hands and Synergy come with the toric versions, then I think we'll have a good option.
But just to compliment you, both your surgeries were flawless. Wonderful.
Thank you, sir.
A lot of things, and it's really good to see steady hands. Even though the patient had tremors, but your hands were rock steady.
Very steady. And there is an excellent viewership both on the Facebook as well as on the YouTube channel for the live surgeries. Yeah, excellent, Dr. Sai.
Yeah. Thank you, madam. Thank you. Can we shift over to the retina side once again?
Yeah.
Just a second, sir.
Yeah.
We are back.
Yes, we are back.
Yes.
Can you have the microphone?
Now we are going to drain the fluid.
There's an external drainage of the subretinal fluid. I just done a scleral flap and expose the choroid, and then I just puncture and relax. And you can see the subretinal fluid just coming with the gush. I never seen subretinal fluid coming like that in my lifetime, like a tap.
Yeah, it came like a jet of fluid.
So I never seen it unless and until it's under pressure inside. But this is a soft eye, so anyway you can see the eye sort of being drained. Yeah. So my full of
Vision?
full drain பண்ணோமா இல்ல It's become very low, so I'm going to put the tire. So this is a
this hypotony. Many times you don't need anything.
So there is another question, Dr. Mahesh, are you there? Meanwhile, when sir
Yeah.
puts the buckle, you can answer.
Yeah.
So Ayush wants to know, in buckle surgery, break is located slightly posterior, just indentable. That should prefer one. What should one prefer? 280 buckle or 276 buckle with 2 millimeter posteriorly placed? Because 280 sometimes is difficult to place due to size.
Yeah. Actually, we used to 280 and even 2.
Your audio. Yeah.
Indentable by how to go to vitrectomy in these cases. That is, a change of plan is going to for vitrectomy. So we don't put either 279 or 280. And if it is in 1/4 like that, we buckle over vitrectomy.
Okay. So again, like I was saying, I was telling Dr. Sai also on the Facebook and on the YouTube, there's a huge viewership, especially for the live surgery. And today also we have the same with high numbers watching on both and quality, which is so good.
So this is a 279 buckle being placed inside the under the suture. And just for completion's sake, regarding the buckle, the tires, there are odd number and even number. This is asymmetric, so you should keep it rightly in the place. If it shifts to that side, this side, the indentation will be different. So this is asymmetric tire should be kept the thinner area anterior and thicker area posterior.
And the procedure should be done as atraumatic as possible.
Yeah.
So, Dr. Mahesh, how is the hypotony going to be addressed in this case?
Once we tighten the tire, the hypotony will go off.
Okay.
So
by tightening the tire, hypotony will be usually overcome. That won't be a problem. But if you still feel there is a chance of choroidal and all, you can reform with air bubble or saline. Both are standard procedures. Now it looks better.
So with a little tightening itself, there is a, good deformation of the eye.
And over the buckle, there is a groove. Over the tire, there is a groove over which we will place the encircling band. We use 240 encircling band, and that will be tightened simultaneously. That will give a generalized construction.
Right, straight.
So eye is formed now. Good buckle effect will be there.
So now I'm going to do, I think I'll have to move out because I'm going to do an indirect ophthalmoscopy and just see inside.
Okay.
So how it is in, how the retina looks.
All right.
The another method many people use is using chandelier, so that they don't have to get up from the seat. So that is another method, but indirect ophthalmoscopy is the gold standard. So in between, we can move to the other case. We will finish indirect and cryo. We will go back to the other case if it is ready. That is ready. Cataract case.
So I think Dr. Sandhya will be operating the last cataract case.
Can we have the Microsoft signal or the OT? We have.
Yeah. So I think we are going to go.
The third case is just getting ready, sir. Just 1 minute. They're just cleaning it up.
You want to say something about your two cases?
Yeah, no, sir. See, I just wanted to, the find out whether this intracameral moxifloxacin or whichever intracameral antibiotic, has it become a standard across the country? Is there any doubt or any confusion regarding that, or has it become the standard procedure across the country?
So I think it has not become the standard procedure as such, although most people would like to give intracameral moxifloxacin, and some like to give it only when they have a complication. And there was this trial which was being initiated by ASCRS, intracameral moxifloxacin versus no moxifloxacin for prophylaxis of endophthalmitis. And it required a huge number, almost to the tune of 75,000 patients. So they did initiate, and this trial was initiated in the pre-COVID era. But because of the COVID, the funding stopped, and so this trial is no longer being done now. At RP Center, we are doing a randomized control study with 15,000 patients, and we've completed almost about 8,500 patients, where we are comparing moxiflox versus no moxiflox in cases of phacoemulsification for prophylaxis of endophthalmitis. So we'll come out with the results, but I think that is going to take 2 to 3 months time, because our recruitment and enrolling also slowed down because of COVID. So
Madam, if I remember right, AOS had initiated some,
so they
some
had
program.
they had done a survey. We had done a survey of how many people are using moxifloxacin for their endophthalmitis for prophylaxis, and only 40% of the people were using actually moxifloxacin, and another 20% they said that they use it only for complicated.
If there is a complication like a PC rent or something like that. Okay.
So at least, in our group, we use it routinely, and we have seen positive effects of that. See, the biggest advantage is that you can just take it out, and now people are even giving it as vials, and that's always preservative free. So I think the Arvind trial, it was, I don't remember, but it was over lakh of cases.
Yeah, it is more than a lakh patients. Yeah.
So that had shown, and specifically also in complicated cases, that it's much better. So it's just like a question of when people are doing a general, say an abdominal surgery or something, they always give a bolus of antibiotics at the end of the surgery, etc. So having a great concentration right at that particular time does make sense to do it. But I think the evidence is gathering. There is no evidence to suggest otherwise. That it causes any significant, 1 or 2 cases of phlebitis, etc. I don't know, maybe 4 or 5 cases of phlebitis, etc. have been reported. But apart from that, we have had rather, touch wood, a nice run with the moxifloxacin.
And anyway, most of the surgeries are now under topical. So I think earlier days, the subconj injection used to be given at some centers. But now, since that has also stopped, I feel that the high concentration of moxifloxacin in the chamber just after surgery would definitely help.
Yeah.
I think that, that would help as of now, but the only thing is, what if resistance develops, then we have to hunt for, another
Correct.
antibiotic, which could be given temporarily.
Have you found any deleterious effects on the cornea, madam? I mean, we have not seen anything, but
No, we've not found any deleterious effect. If you see the literature also, the specular microscopies have been done in limited number of patients, not in the cohort where large numbers were there. They just took a subset and they examined, and there was no deleterious effect on the endothelial cells.
okay, madam. Thank you.
Namrata, just to kind of have a discussion on that particular thing, the only thing is that routinely moxifloxacin is being used for left, right, and center for conjunctivitis, and it is also being used pre-operatively and post-operatively. So basically, it's the quantum and the delivery site that is different, because pre-op you are giving moxifloxacin and post-op, and if you give intracameraly, I don't think there's going to be a difference as regards the development of resistance from that particular thing. And the other important thing is that it is not available for veterinary use. We often ignore that particular fact that it is large doses of veterinary use that is being used for other antibiotics, which is causing these resistance.
Can we start the third case, madam? We are ready.
Oh, sure. Go ahead.
Can you shift to the camera view? Dr. Sandhya is operating.
Yeah, please give an intro on the case.
This is a 60-year-old gentleman with a grade 2 nuclear sclerosis, routine cataract. Again, we are planning to put an eye hands for this particular patient.
It's an NS2 plus cataract. You please moderately dilated.
What is the power of lens that you would be using in this case?
Eye hands lens, madam.
Power?
Power, just around 27 diopter, I think. It's 27, no? Yeah. So I'm just staying a capsule with trypan blue. We all stay in the capsule under air bubble.
Can you just tell the viewers the advantage of using air?
Trypan blue, sir?
Air. Putting trypan blue under air. What is the advantage?
Yes, sir, because it won't stain the endothelium. Then our view will be very hazy. So we all stain it under air bubble. And we finally we put gel.
And also, I think when you do it under air, then you don't dilute the trypan blue. Because you've already taken out the aqueous and then the air is going in. So the dilution of the trypan blue doesn't occur. I mean, the color doesn't become light blue. It remains what it is supposed to be.
So the advantage are twofold. The second is that the air also acts as like a tamponade. So you can gently, evenly spread the trypan blue under air, and it's a tamponade. So the one is no dilution, good tamponade, and the obviously the other advantage is
it won't get mixed up with the gel.
Yeah.
Red glow system. So sit centered. Yeah.
That is centered somewhere.
I'm aiming for a 5 millimeter axis so that it overlap the IOL optic all around. So here I am using the iris margin as a guide for my request.
I think very nice needle rexes, and then you completed it and then made the main wound.
So gentle hydrodissection is being done. So after hydrodissection, I'm just pressing the other edge to take out the fluid so that the back pressure won't be very high. So in normal cases, if the zonules are strong, then we make sure that the nucleus rotates well.
So just slightly center it towards your right. Yeah, yeah, yeah,
Is it fine, madam? Now?
yeah, yeah.
So after nucleus rotation, I'm just sculpting the nucleus. Centered on us, no? Okay. Still. So as you go down the trench, you have to deepen your focus and then go to the depth of the trench and then crack it. What I'm doing is stop and chop. And after cracking the nucleus, then I'm going to chop it. Quad. After chopping it, I'm slowly taking out the pieces, one against a quarter one. Jelly biscuit. So this is the dispersive viscoelastic that is going in to protect the endothelium. Got it. Can use the second instrument to bring the pieces to the center of the phaco probe. Epinucleus. Parasympathetic.
So I think if you put the machine on the epinucleus mode, it always helps because it will, slightly, all the parameters would go down slightly with the epinucleus mode.
Epinucleus, because we want to protect the capsule, so all the parameters will be going down. So here I'm using the Simcoe cannula. I use bimanual also, but I'm more comfortable with Simcoe. This is the piece. You have got a small epinucleus piece. So you have got two options. Either you can put the probe and take it out, or you can remove it like this.
Mm.
Second with the roster dial.
Suddenly become very dark.
Yeah.
Can you
That's
just
because it's the red glow, MSN.
I
just
think that's fine.
remove the coaxial maybe?
Yeah, yeah.
Retro, yeah, that's better.
Now it has become better. Otherwise,
So the small epinucleus piece that is there, either you can remove it like this or. Okay. Since the incision is beveled, it won't sustain it. Dial. Let's go.
Viscoelastic also, yeah, one can. So I think you can have sometimes these fragments and they can be present at the main wound. You discover them or at the side port or in the iris, crypts of the iris fragments. And when you just take out your main handpiece, your IA probe, or you take out your chopper or your second instrument, then you realize that these are hidden under these three areas most likely. And sometimes when you have a high myope, then also they will go and hide underneath the iris. And when you do the irrigation aspiration, then suddenly they will come out from
Yes,
somewhere.
madam. Yeah, yes, madam.
So one has to basically address them later, and then you can visco express it out, or you can take it out with the irrigation.
Sometimes use a second instrument to just make it small and then take it out to the tunnel.
To chop it with the second instrument and stuff it like a lollipop into your Simcoe cannula or your IA probe or into your bimanual irrigation aspiration. I think the video link is suddenly stopped. So
is there someone from the Girdhar Eye Institute? I think we lost the link.
So we are checking, sir.
Okay. So these are the three ways of just taking it out. And I think best is that if it is still there and if it's a big chunk, then best is go with your phaco probe and then just give a small burst of phaco and then take it out, because sometimes it can take long time to.
So Dr. Namrata, another thing is visco expression, because I normally don't wish to go in with a probe again because there is no support that's left. So you can put in the methyl cellulose and depress the wound, the main primary incision, and take it out. Or at times it comes and sticks at the primary incision. So you can use a Rex's forceps or a McPherson. Rex's forceps is better, and try to kind of pull it out. But as was being discussed earlier, leaving these inside, we need to be watchful because they don't get absorbed as long as they are nuclear pieces. But one thing I'll just like to say is that over the years, the expertise, the dexterity, and the skill of Indian surgeons in phacoemulsification has grown by leaps and bounds. So it's every time you see a Surginar or a live surgery, you have new people doing excellent, flawless surgery. And I think the skill sets have really improved along with the machines that is there. There are so many learning methodologies that are available. And I think the live surgery is also one of those where you can actually see how situations are handled by different surgeons.
So, can we have the link, if not from that OR, from the other OR, the retinal?
Link has gone. Might be some power outage or something.
No, sir. I completely agree with you. Watching live surgeries has made things much simpler. And seeing even the technology has advanced so much that you can now record almost everything. And I think we have a message from there which says that we are connecting with the OT. So all these things have helped, and I think over the last 1 year, and I'm sure you also would agree with this, in the COVID times, there has been a lot of educational material on the web, which earlier was not there. And so people can refer to it and people can watch it without actually having to travel, without actually having to spend, and without actually having to, they can do it in their own time frame. they can watch it later also. So suddenly there is a surge of surgical as well as didactic lectures, cases, everything on the web.
I
Which is
think
not there.
we have got them back.
Yes.
Do we have the OT? We had the signal, but again, I think it's frozen. Are you there, Dr. Sai? So I fully agree with you that, sorry, yeah, you can continue.
Yeah, the
Yeah.
lens is being implanted. It's the Eyehance lens, 27 diopter. So sometimes this haptic will get stuck to the optic, so you will have to release it slowly.
So can we have the because it's a retro again and little dark? Can we have the
Yeah, yes, madam.
yeah,
Normal.
yes.
Yeah, normal.
Anything special you'll wish to tell the audience which you will do for, like, it's plus 27. So maybe I'm just talking about small eyes or hyperopic patients and high power IOLs.
IOL power, sir, you mean?
Yeah.
So basically must be a small eye, right? The
Yeah, it's a small eye. In all eyes, whether it's a small eye or normal or long eyes, we all go for Barrett Universal 2 formula. So because it gives it's robust throughout the axial length. So we use a Barrett Universal 2 in all cases, and the other Von Hill formula are also very useful.
Okay, great. My question was actually on the surgical.
Surgical aspects of, yeah.
Yeah. Anything, supposing you have an ophthalmic eye or a small eye, what would
It's
be
better to
yes.
we can give mannitol or mannitol. We usually give mannitol 1 hour prior to surgery so that the posterior pressure will be slightly less. And then we always do CCC through the side port. So we don't open up the main port unless the CCC is complete. And then it should be a closed chamber always. And you should have a backup of the VR team. In case anything happens, you should always have a backup VR team. So we always operate non-ophthalmic cases or something. I usually don't do very complicated cases, but we always do it when the retina people are around. In their OT, we do non-ophthalmic cases, so that if anything happens, we can get their help.
Okay, so I think now you are aspirating the viscoelastic from behind the IOL as well as from in front.
Yes, madam. For now, I'm aspirating from behind the IOL. Then I am placing it in the center of the bag.
So it is important that all the viscoelastic comes out, and there are 2-3 signs you can actually see it coming out. Second is that sometimes you can see PC stria, which is there if your entire viscoelastic is out. And third is that the lens will become, suddenly more wobbly as compared to what it was before as the viscoelastic is aspirated. So
Yes,
you know that the entire viscoelastic is out. I think very nice surgery, Dr. Sandhya.
Thank you, madam. Now I am finally hydrating the wound. Then coming to viscoelastic, viscoelastic, it comes out very easily, unlike dispersive ones. So it comes out very easily. So even though the retention is more likely to cause IOP rise, it comes out pretty easily.
And you would also use intracameral moxifloxacin in this?
Yeah. Yes, madam. We take it in all cases. It is routine in our hospital.
Anyway, I'll wish to compliment you, Dr. Sandhya, for an excellent exposition of this surgery.
Thank you, sir. Thank you very much.
Any specific points you wish to add?
Regarding the surgery or the lens, what's
either or the surgeon?
Yeah.
Okay.
I guess maybe sir, you are asking about the lens probably because she has implanted the Eyehance lens.
Yes, sir. Eyehance lens. It's basically a monofocal lens, but it gives good intermediate vision also. So basically, in two situations, I put when the patient can't afford for multifocal or their preference of work is something on the laptop or computer, something like that. And also in some patients, they want some spectacle freedom, even though they have some retinal pathology like diabetic retinopathy or something. In such cases, definitely I tell them the option of high hands because they can avoid glasses at least for intermediate vision. So they'll have to wear only for near vision. So in such cases also, I would prefer eye hands.
So are we ready on the other OR where we had to finish the pediatric retina case?
Yeah.
Yeah, Dr. Girdhar is
There,
ready.
these are all the three cataract cases, right?
Yes, sir.
Great.
Yes, Dr. Mahesh.
Yeah, here we have drained and given little more cryo. Now you can see IOP as even without forming the vitreous cavity, intraocular pressure is almost normal after tightening the buckle and band. Sir, any comments?
You're asking Dr. Girdhar, I suppose.
Yeah, Dr. Girdhar is here.
Yeah. So we are not in a position to give any comments.
Yeah. No, it is almost completing. So after that, we'll suture the tenons and conjunctiva in layers. Both has to be approximated properly. Otherwise, there could be buccal extrusion and other complications.
So
So
do you
maybe
prefer to drain in all the
come up
buckling cases?
Sorry, go ahead, Rajesh.
I just wanted to know whether you prefer to drain in all the buckling cases or you select and then drain out.
In all?
Do you drain in all the buckling that you do or?
No, not necessarily. Some cases where there is a shallow fluid, once we tighten the buckle itself, that break will become flat over the buckle. So you don't need to drain. Here, little fluid was little more. So the break is not becoming flat over the buckle. So we
What was
drain.
the duration of detachment? Many times,
This was a 17-year-old boy, actually, probably a couple of months because he was not giving proper history. They had a previous eye check a few months back. He was okay. So this is the history is not very reliable. Probably a couple of months, definitely. No PVR.
Yeah. Okay.
Inferior retinal detachments, you have to always drain till the break is flat on the buckle, because otherwise the fluid will again lift up the retina and cause recurrence. Inferior retinal detachment has to be completely drained if you are doing a buckle for inferior RD. But superior RD, you can leave little fluid and then even inject one air bubble which will tamponade the break.
Absolutely.
Dr. Mahesh, there's a question. What is preferred pace of drainage to minimize risk of subretinal fluid post-drainage? This is on the Facebook.
Actually, ideally, it is mentioned above and below the lateral and medial rectus. That is the area where there is least
maximum fluid you drain.
That is one theory. And as Dr. Girdhar is telling, wherever there is maximum fluid, you have to drain, because it depends on the topography of the retinal detachment. So you can avoid, if there is a lot of fluid, you can avoid areas near the vortex and all. Otherwise, wherever there is maximum fluid, you have to drain that.
Any comments to sum up the surgery?
Comments, basically, I mean, we have done buckling with drainage. And basically, I mean, there is a 90% chance of success in this one surgery. I mean, in this particular case, we have sealed all the breaks and we have drained as much of fluid that is necessary, possible. So,
any post-operative advice for this patient, sir? If there is any residual fluid, or for the benefit of everyone?
Post-operative advice, if there is residual fluid.
Post-operatively, if there is residual fluid and the breaks are all closed properly, you should wait for sometimes, because basically in buccal cases, it takes a little time for the residual fluid to disappear. So one should not be in a hurry to go for a resurgery. But if you find that, on the table it was practically attached and within 1 month again there is a reformation of fluid, then definitely it is because of it's a redetachment. So residual subretinal fluid after buckling with where the breaks are all well sealed, one should definitely wait. One should not be in a hurry to go in for a resurgery. Yeah.
So that is the difference between residual and recurrence.
Yeah. That is I think the correct message.
Yeah.
Again, there is this question, if there's a subretinal bleed post-drainage, what should be the head position post-surgery? Or can we put air, gas and give prone position to avoid bleed to reach the subfoveal region?
Yeah, actually, if there is a hemorrhage, we have to avoid it coming under the macula. So you can keep the go towards the foil. That is the correct method. Sometimes we inject gas bubble also, so that. But usually, once you tighten the buckle, this will stop the drainage site bleed. Usually, the bleed will be from the drainage area.
So,
That will stop.
Yeah, as far as the hemorrhage during drainage of subretinal fluid is concerned, number one, how do we prevent it? So by choosing an area which is less vascular, that is why we choose, normally in a detachment, we usually drain below the lateral rectus. So if you drain in the inferior meridian, the chances of the hemorrhage coming into the macula is reduced, number one. Number two is before you puncture, there are various methods. Nowadays, many surgeons directly puncture with a fine needle for drainage. Basically, with that, probably the hemorrhage chances are very less. But if you're exposing the choroid, you can just see whether there is any choroidal vessel. If there is a choroidal vessel, avoid that site for drainage and go into another area for a subretinal fluid drainage. So I think if you are very careful, the chances of a hemorrhage during subretinal fluid drainage is very, very less in scleral buckling surgery. So once you get a hemorrhage, as Mahesh said, these are some of the ways by which you can manage. But if there is a massive hemorrhage, probably you may have to change your surgery and move into a vitreous surgery also, isn't it? Do a vitrectomy and, give a tamponade. And you may have to do
Rarely required.
But then it's very rarely required.
I think with this, we come to the conclusion. Is there anything else that needs to be shown, or can we have your last words, Dr. Girdhar, sir?
You can.
We had a wonderful case demonstration. All the 3 cataracts were excellent, went, absolutely perfect, like perfect pictures. And so also the retinal detachment surgery, for us, it was a treat to watch. And the transmission of the retinal surgery was just excellent.
Sorry, I missed a bit because I was traveling and I was driving myself. But whatever I could see, it was really, wonderful.
So I think we wish to thank the organizers. Dr. Girdhar, you want to say anything at the end?
No, I would like to thank the and I hope this session was useful for all the ophthalmologists who are, online, and both the primary aim was to show cataract surgery, but since we thought we'll just also show some retina. Actually, vitreous surgery might have been more interesting, but unfortunately, the patients whom we had scheduled, there were some issues with the patients, so we had to last minute cancel them, and this was a pending buckle. And since tomorrow we are not doing any surgery because we want to clean the OT complex after 2 days, just finish off this buckle today. So otherwise, I thank Mahipal and Mamrata and Rajesh Sinha for giving us this opportunity, and I hope it was as good as you had expected.
Sir, what I felt was that buckling surgery is very less often demonstrated. So I think it was wonderful to have a buckling surgery demonstration. We get to see vitreous surgery like vitrectomy, other things demonstrated more often, but buckling is less often demonstrated. So I guess it must be very useful for the viewers who have seen this.
I think, sir, it's a useful resource for people to refer back to also later who've not seen just now. And we'll have the vitreous surgery and another set of cataracts on another day from Girdhar Eye Institute. And
with pleasure, madam.
Anyway, I wish to congratulate you for a flawless execution. And while your connection was off, I was just remarking that the excellence in surgery and the skill set was there to demonstrate. And it was really a pleasure. And Indian surgical expertise is really growing by leaps and bounds. Every new surgical session, we come to see new people operating. And as I say before, and I say again, that Indian ophthalmology is in safe hands as we have the Gen Next coming in and doing an excellent work. So great, I would say, and thank you very much for an exposition of cataract and pediatric or retinal detachment surgery with an external buckling and encephalage.
Thank you so much.
Thank
So
you.
I think
Thank
it's
you,
a,
thank
it's a
you, thank you.
wonderful platform to have, because people don't have to travel now. So they can see, sitting in their own houses, the surgeons can operate in the comfort of their own ORs without having to move here and there. And everybody can watch it on the laptops.
Amrita, you can thank
So
the
thank you.
organizers and the sponsors.
Yes. So we wish to thank J&J, Johnson & Johnson, for organizing this, and our audiovisual team at the back. And thank you, sir. We've already taken a commitment. We'll do it again. So it's on record now.
We can do
So
it.
we'll
We
come
can
to
do
you.
it. That's not.
Have a great Holi.
Thank you.
Yeah, happy Holi, everyone.
Thank you.
To all of you.
Happy
Yeah.
Holi to all of you.
Yeah. Only with social distancing. I don't know how it's possible.
Somebody
Okay.
just commented a dry Holi, and a friend of mine said not dry in that sense.
Okay. Bye. Bye.
Thank you. Bye-bye. Thanks.